Hello, my name is Rupert B. Laco. I am a Captain United States Air Force, and I'm here to present my Doctor of Nursing Practice Quality Improvement Project titled A Simulation-Based Training Program to Improve Cardiopulmonary Resuscitation and Teamwork Skills for the Urgent Care Clinic staff. Before I start my presentation, I am reading a disclaimer due to my position in the United States government. The views expressed in this presentation are solely those of the authors and do not reflect the official policy or position of the United States Army, the United States Navy, the United States Air Force, the Department of Defense, or the U.S. government. Introduction. Why the topic is important. Lack of high-quality cardiopulmonary resuscitation or CPR and effective team communication during cardiovascular emergencies could lead to poor patient outcomes and adverse effects. Studies have shown that CPR psychomotor skills decline 3 months and plateaued up to 6 months after the completion of CPR training. The urgent care clinic is located in a military base without immediate access to an emergency room level services. The UCC interprofessional staff also does not receive consistent training on CPR and teamwork skills beyond what is received from the biannual American Red Cross Basic Life Support Training and semi-annual Resuscitative Care Function Mock Cardiac Arrest. 12 participants have taken their last cardiopulmonary resuscitation training for more than 6 months. 2 took their last cardiopulmonary resuscitation training between 3 to 6 months, and 4 participants took their cardiopulmonary resuscitation training last 3 months before the pre-intervention period. Furthermore, we evaluated 32 mock cardiac arrests and 4 real-world cardiac arrest events from January 2015 to February 2020 for non-compliance with associative care science, team communication standards, and the worthiness of the project. So in total of 36 events. You will see in this bar graph that the gray side is the compliant, and then the dark yellow is the non-compliant items. For recognition and activation of emergency response system deficiencies, there were 13 code events that did not meet the American Red Cross Basic Life Support Standards. The summary of findings include healthcare providers who did not call for help, did not know how to activate help, delayed activation after recognition of an emergency, and did not use the overhead paging system to call for help. When it comes to the performance of chest compression deficiencies, there were 15 of the code events that did not meet the American Red Cross BLS standards. The summary of their findings include healthcare providers who did not initiate chest compressions timely, held compressions for more than 10 seconds, and did not perform chest compression with appropriate rate, depth, ratio, and technique. For the delivery of ventilation deficiencies, there were 15 of the code events that did not meet the American Red Cross BLS standards. The summary of findings include healthcare providers who did not deliver ventilation timely, delivered ventilation for more than 1 second per breath, and did not perform ventilation with appropriate airway positioning, ratio, and technique. Lastly, for the execution of teamwork skill deficiencies, there were 13 code events that did not meet the team strategies to enhance performance and patient safety or team steps recommendations. The summary findings include healthcare providers who did not converse with checkbacks, did not perform call-outs, and did not perform brief and other concepts within the team steps curriculum. Thus, additional training and practice to improve CPR and teamwork skills have received patient safety and medical readiness priority in the hospital and the urgent care clinic. The purpose of the project is to form an interprofessional team to lead the development and implementation of theory and evidence-based simulation-based training program to improve CPR and teamwork skills while enhancing patient safety and emergency medical readiness in the urgent care clinic. The overall aim is to improve cardiopulmonary resuscitation or CPR and team communication skills of the urgent care clinic staff by July 2020 as evidenced by a 10% increase in their CPR competence and perceptions of teamwork. The project has 3 objectives. First objective, the interprofessional team will establish a quarterly simulation-based training program with a training plan, learning objectives, and clinical scenarios to improve the urgent care clinic steps, emergency medical response, recognition and activation, chest compressions, deliberate ventilations, and communications during CPR. Objective number 2. 90% of the UCC staff will attend a simulation-based training program with briefings and debriefings conducted by trained facilitators. Objective number 3. 90% of the UCC staff will receive face-to-face training on the American Red Cross basic life support and team strategies to enhance performance and patient safety skills to improve their competence and perception of teamwork. Methods. Subjects. We selected the first 18 volunteer participants due to the coronavirus 2019 class size limits and simulation equipment availability using the voluntary response sampling method. The UCC participants are between the ages of 18 to 39 years old, which contain 10 officers and 8 enlisted personnel. Within that 18 personnel, there are 5 physicians, 5 nurses, and 8 medical technicians. The inclusion criteria are participants that are assigned to the UCC, and the exclusion criteria are participants that are not assigned into the UCC. Settings. The UCC provides a routine to an emergent stabilization level of care in a setting of limited emergency resources and a hospital without intensive care capabilities. In regards to training equipment, the hospital has a simulation department with high-fidelity simulators and 1 simulation operator. The simulation department has equipment and supplies that are located locally, so there is no need for logistical coordination, transportation, and additional cost for equipment, supplies, and travel. Methods. Tools. We use the American Red Cross Basic Life Support's curriculum's prescribed skill sheets to evaluate the urgent care clinic staff's members' CPR competence. The skill sheet is designed to assess the participants' CPR knowledge and psychomotor skills regarding the treatment recommendations from the 2015 International Liaison Committee on Resuscitation and the 2015 American Heart Association Guidelines for CPR and Emergency Cardiovascular Care. We also use the 35-item and 5-category tool Team Steps Teamwork Perception Questionnaire, or TTPQ, to evaluate the UCC staff members' perception of teamwork. The TTPQ tool has been used in several studies and was demonstrated to have a high validity and reliability scale in assessing participants' perception of teamwork. Methods. Interventions. We use the Deming cycle of continuous improvement model, also known as Plan, Do, Study, and Act, or PDSA model, to improve CPR and teamwork skills in the urgent care clinic. In the plan phase, we gave the project information sheet to UCC participants and informed consent was obtained from all participants. During this period, we also formed an interprofessional team to develop a theory and a simulation-based training program. During the Do phase, we led an interprofessional team to train simulation program facilitators on simulation-based training's high-fidelity mannequin, pre-simulation preparation, briefings, and debriefing. Within the same period, we led an interprofessional team to assess the CPR and team communication skills of the UCC staff using the American Red Cross Basic Life Support Skill Sheets and TTPQ questionnaire. After the collection of pre-intervention data, we conducted an American Red Cross Basic Life Support and Team Steps in situ simulation training. In situ simulation training is defined as simulation that occurs in the actual clinical environment and whose participants are on-duty clinical providers during their actual workday. During the study phase, the interprofessional team reassessed CPR and teamwork skills using the American Red Cross Basic Life Support Skill Sheets and the TTPQ questionnaire. Lastly, the ACT phase. We analyzed pre-intervention and post-intervention data to see if the project aim was met or modification to the simulation-based training is needed. Methods. Data collection. The CPR competence data were collected using a direct observation method via the American Red Cross Basic Life Support Skill Sheets by the project's interprofessional team, and the data collection occurred during the project's pre-intervention and post-intervention periods. The facilitator marked the skill sheets as a standard met or standard not met for each of the required categories. On the other hand, the perceptions of teamwork data were collected using the TTPQ questionnaire. The urgent care clinic staff completed the questionnaire, and the data collection occurred during the project pre-intervention and post-intervention periods. We administered the 35-item questionnaire to the participants. We entered the participants' answer for both basic life support skills and teamwork perception to the IBM SPSS data management system for analysis. Methods. Data analysis. We analyzed and compared the pre-intervention and post-intervention data for the CPR competence. The collected data were quantified as to how many American Red Cross Basic Life Support standards were met, score of 1, or how many standards were not met, score of 0, in the 10 categories of the participant skill sheets. Moreover, we analyzed and compared the pre-intervention and post-intervention data of the urgent care clinic staff's perception of teamwork by a completed TTPQ questionnaire. The participants' answers were quantified as they placed a checkmark on every box with a Likert scale rating from strongly disagree, score of 1, disagree, score of 2, neutral, score of 3, agree, score of 4, and strongly agree, score of 5. We analyzed the participant responses from each team's steps construct. Furthermore, the analysis and comparison of all pre-intervention and post-intervention data of the BLS skills and teamwork perception were completed by a paired t-test to see if the overall project goal is met. Results. Basic life support skills. A total of 18 participants completed the American Red Cross Basic Life Support pre-intervention and post-intervention assessment. On the left side, you will see the BLS skills percentage scores, and the right side is the BLS 10 category skills that we assess. Coming back to the left side again, you will see that the pre-intervention mean score of 45.42 increased during the post-intervention period with a score of 89.21. Going back to the right side again, you will see for participant CPR recognition, activation, emergency response skills, there's an increase in competence levels with a pre-simulation mean score of 0.50 and post-simulation mean score of 1. Likewise, there's also an increase in participant CPR full chest recoiled with a mean score of 0.55 and a post-simulation mean score of 0.94. For participant CPR hand placement, there was also an increase in competence levels with a pre-simulation mean score of 0.33 and a post-simulation mean score of 1.00. Similarly, there's also an increase in the participants' opening of airway was recorded with a pre-simulation mean score of 0.11 and a post-simulation mean score of 0.94. Results. Teamwork perceptions. A total of 18 participants participated in the pre-intervention and post-intervention teamwork perception assessment. On the left side of the screen, you will see the accumulated responses of all participants equaling to 630 questions. On the right side of the screen, you will see the percentage scores per each team construct. Going back on the left side, you will see that there is a significant increase in the participants' teamwork perception levels with a pre-simulation mean score of 4.61 and a post-simulation mean score of 4.86. Going back on the right side of the screen, for the UCC's team structure, there is a significant increase in the perception levels with a pre-simulation mean score of 92.22 and a post-simulation mean score of 95.87. Likewise, a significant increase in the UCC situation monitoring with a pre-simulation mean score of 90.47 and a post-simulation mean score of 98.25. For the urgent care clinic's mutual support, there is also an increase in perception levels with a pre-simulation mean score of 92.06 and a post-simulation mean score of 98.09. Similarly, there's also an significant increase in the UCC's team communication was recorded with a pre-simulation mean score of 90.79 and a post-simulation mean score of 96.82. Discussions. The project simulation-based training strategies included facilitator training and preparation of their delivery of briefing and debriefing. To meet this evidence, the simulation facilitators completed the Air Force Medical Modeling and Simulation training courses and are certified American Red Cross Advanced Life Support Facilitators and Trusted Care Safety Behavior Coaches. These interventions support the evidence that simulation allow participants to effectively rehearse their CPR skills if accompanied by an expert or trainer's feedback. We also perform pre-simulation briefing to familiarize participants with the high-fidelity mannequin and other simulation equipment to include the bulb mount mask or BBM, CPR stool, and CPR board. We use different scenarios in every simulation-based training session to provide complexity to team functions. The participant used the team steps briefing checklist to set clear roles and team objectives before the simulation after we read the scenario. This intervention supports the evidence that briefing could improve the participants' acquisition of knowledge during simulation-based training. During the simulation-based training, we also provided real-time CPR performance feedback to the participants using the program American Red Cross BLS metrics within the high-fidelity mannequin simulator. The CPR metrics include hand placement, depth of compressions, analysis of full chest recoil, compression rate, and analysis of ventilation volume. This intervention supports the evidence that high-fidelity simulation training produces increased CPR performance versus to a low-fidelity simulation training or trainer. Conclusions. We completed an American Red Cross Basic Life Support and Team Steps High-Fidelity Interprofessional Simulation-Based Training Quality Improvement Project. Our results demonstrated that the participants' American Red Cross Basic Life Support scores and the urgent care clinic's team perception have increased after in situ simulation-based training, thus meeting the project's goal. Simulation-based training can provide in situ training opportunities for participants to recreate real-life application of skills, knowledge, attitudes, and behaviors, and enhance team-based learning in a safe environment. The improvement of CPR competence and teamwork skills in the urgent care clinic can increase their patient population survival rate and patient safety during cardiovascular emergencies. A high-fidelity simulation-based program with trained facilitators that quarterly assess the healthcare provider CPR competency and teamwork skills could enhance the delivery of high-quality CPR and execution of effective teamwork skills in their workplace. Limitations. The limitation of this project include the limited number of participants, and because of that, we might not obtain definitive results. The project also did not assess the effects of popular songs to the participants' compression rate skills. The mixture of mental imagery tied with motor stimuli and song familiarity synchronizes the sensory motor system, which develops the beat timing during compressions. Lastly, we did not study the challenges that the teams face due to the frequent changes in team composition. Recommendations: we did not assess the effects of simulation-based CPR in team training to clinical practice. Studies are needed to demonstrate how simulation-based training translates to practice and its influence to patient safety. Furthermore, we did not analyze the optimal time for refresher training. Studies have shown that CPR psychomotor skills decline 3 months and plateaued up to 6 months after completion of CPR training. We recommend a longitudinal study to determine the optimal time for CPR refresher training.